Hey everybody, this is Erica Mello, and welcome to episode number 226 of Tough to Treat. And Susan and I hope you all had a really wonderful summer. It's always too short, I think, at least for me. We end up in September, which for me is one of my favorite seasons, the fall in New York City, where I am. It's a great time to be here in New York. The weather is definitely better. We've had a really, really hot summer, but it's definitely better now, and it's cooler. So we're looking forward to giving you some newer episodes going forward. And this episode is sort of a short week, and it is about a patient of mine who, and this is going to be really focused, super focused, on has had chronic right hip pain, and it got better, then it got worse, very sort of typical scenario. And I talk a little bit about her past movement history or past injury history. She had torn her hamstring twice on that side. And she also suffered a hyperextension injury during the pandemic. So I'll just go with you just through a little of this to be super focused on the knee. For those of you who know me, I obviously look at the whole person, right? Sort of a true whole body approach, and I assess the relationships of the regions of the body to each other. But this is going to be a super focused one on the knee, and I can explain a little bit more as I go in. But we hope you enjoy the podcast, and we will see you live on the next episode. Hey, everybody, this is Erica Mello, and welcome to episode number 226 of Tough to Treat. And for those of you who are listening live when this comes out the end of September, happy fall. And as I mentioned in the intro, it's my favorite time of the year. And so in this episode, I'll get right to it. For those of you who are listening on a podcast app, we do a YouTube channel. And if there's something that you're missing, if there's something that I'm showing, I tend to talk a lot with my hands. Just pop over to our YouTube channel at Tough to Treat, and you'll get a better idea of what I'm talking about. But I didn't think this episode is really strictly about the knee. So it's about a patient of mine who I've seen on and off for a long time for various injuries. And I think the older you get, the more compensations you have, and until you can't compensate anymore, and you start to sort of accumulate many injuries. And this is a very sort of typical caseload of mine. And she had many injuries over the years, bilateral ankle sprains, left hip issue, shoulder radiculopathy, neuropraxia on her left quad from a femoral nerve and obturator nerve injury, many issues. She came in to see me with right hip pain, sort of that chronic tightness in the glute, in those deeper rotators, very, very common, right? Really, walking was her main symptom. Stairs were pretty okay, and you'd think, gosh, if the hip was the driver, I mean, going up the stairs is, really high load on the hip, especially, here in New York, especially when you go up subway steps. So that really didn't bother her a lot, actually. It was mostly walking, more with the heel strike. And that's when she would feel it in the glute. And like a typical patient, she'd be like, when I sort of touch that area, or when I push it to like make it feel better when I'm walking, all my symptoms go away. And I'm like, of course they do. I didn't obviously say that, but yes, because you're giving neural input into your system, and many times it does make people feel better. But I want you to think about the assessment on that same side. So her center of mass was actually to the right side. She's loading that side, which in and of itself is questionable, right? Why is she loading a side that has been so problematic for her over the past few years? Insidious onset. It did get better at one point, she said, but then it just started to get worse again. So on that same sided leg, I'm going to skip the whole sort of whole body assessment that I talked about in the intro, and I'll skip, parts of her story, because I wanted this to be a super focused episode, and it's a short one. Okay. But I want you to just come away with one tidbit or one piece of information. How many of you who, after you've done your assessment and you've determined that the knee, for example, is the driver? Not common in my population, right? The knee generally is the victim, but how many of you actually determined that the knee is the driver. Raise your hand. But just think about that, right? Someone comes with hip pain, foot pain. Is the knee the driver? Sometimes it's not. It could be a secondary issue for sure. But with this patient, her knee actually was one of her drivers. And that is not, as I said, not a common presentation. She wasn't complaining of knee pain. Really wasn't. So the issues on her right side, she tore her hamstring in 2015 very badly, probably grade 2. Bruising, really bad, like out for months. So you think about that, and we know those things, those injuries don't come back by themselves. You have to work at that, literally, and they will happen again, which it did in her case in 2021. She tore it again, very minor strain. She was bent over to pick up something off the floor and tore it. Her first injury was someone was in front of her and the person sort of fell. And instinctually, she grabbed that person to help, and then she tore her hamstring. So that was the worst one in 2015, 2021, less so. But nonetheless, the weakness still persisted in the hamstring, the imbalance, I should say. And during the pandemic, she was walking on the street and she hyperextended the knee. So the right side. So she was walking and she felt the knee go into hyperextension. She heard like a pop. And, she didn't, knew me, and basically, reached out to me and I saw her briefly for that. And I didn't really see anything chronically wrong with that. And so sent her on her way. And now she's back recently for this sort of hip pain that's been coming, right? So you want to think about what does a hamstring tear do to the mechanics of the pelvis and to the knee, and also for the foot, for the whole system, basically. But we're going to hone in on hip, knee, foot, mostly hip and knee. Hip pain, and she had 2 hamstring tears and hyperextension injury of her knee, which, as I said, I treated her for a few sessions. She was better. It was an acute thing back in 2021, good to go. But now, 3 years later, life happens and maybe more walking, and she has had this chronic sort of really deep rotator pain. Does some stair climbing at home, would get a lot of numbness down her leg. And we're thinking, well, jeepers, nerves don't like to get compressed. It could be those deeper rotators compressing on her nerve. I ruled out all of the neural tension, but I took a look at her in standing. And there are many, many patients that we see. And as I said, this is going to be a super focused. So it's her right leg. If you just we all assess the knee differently, but if you just put your hands on the patient's femur from behind, you're kneeling down from behind, feel the femoral condyles, just close your eyes and get a sense of where that femur is in space. You can take that information at its face value, right? And do with it what you want. But I find that helpful to see where people start. Her femur was significantly internally rotated, not unusual. Many people have that, right? But then you open your eyes, and I would really, really, really urge you guys to use a mirror, and you can see that in her, just using here, if you're on YouTube, her tibia had significant lateral translation, right? Significant. So that would cause a lot of compression, and most likely on the lateral joint line and maybe some on the medial joint line. Not a happy knee, but she wasn't complaining of knee pain. So how many of you, what do you do when you assess knees? Do you just hop them on the table? With her main issue was her hip, and it was really primarily with walking. So bear that in mind. And I did watch her walk. And so, but I wanted to assess the mechanics of the knee because of what I saw in the mirror. So I had her squat. And so you can go back to the mechanics of the knee and how we all learned it in school. But, I tend to close my eyes first. I would train my hands. And when she squatted, it was, her femur actually externally rotated. It did what it was supposed to do, right? But then it kept going, right? And so, but with her, it actually got a bit better when she squatted. But in her tibia, not so much, right? And so she had a resting, sort of significantly internally rotated femur. We see this all the time. But when she squatted, her I don't even want to say alignment, but the mechanics of the femur got better. Okay. And you could see that in the mirror. So her tibia, though, still maintained this lateral translation. So there's a lot of torque going on at the knee joint there, and not a happy knee. But once again, she was not complaining of knee pain with a squat. Stairs were fine, going up and down. So would you really assess a squat on somebody who has that narrative? If you had to pick one movement, probably not, right? Because she had no problem squatting, no problem going up and down stairs. I'm just, explaining this to you because she didn't have knee pain, right? And so sometimes when I go in on a patient's knee, I'll have them bend the knee or squat a little just to get my hands in there and get my thumbs around the bulk of the hamstring, right? So I assess both movements just because I had the time and I could. But if you had to pick one movement, a squat wouldn't be it, correct? I hope we're all in agreement on that. If you had to pick one, okay, and sometimes we have the luxury of picking more than one. But with hers, just with walking, do we squat when we walk? Not really, right? We don't really bend our knee that much. A little bit when the foot is on the back, when the foot's from behind, and we're transitioning. But it was really when she stepped forward onto her right foot that the glutes, everything just really locked up on her. And so I assessed what movement do you think what movement do you think you should assess in standing? Because sometimes, at my skill level, I can look at gait, but you need to get your hands on somebody, and it's kind of hard to do that when somebody's walking. So think about the movement that you need to assess in standing. That's not squat. That's not knee flexion, right? You need to assess terminal knee extension, not just knee extension, terminal knee extension. Why? Why with her? She hyperextended her knee during the pandemic. She had a hyperextension injury to her knee, and she's super hypermobile. So you're going to assess that. And so you look in the mirror and you train your eyes, take your hands off, and just have them go into that hyperextension if they can. They need that screw home mechanism. They need terminal knee extension. You need that. You need that to function with a healthy knee. Her knee wasn't really healthy. I mean, it wasn't painful, but she had a lot of torque in her knee when she squatted. But it didn't bother her. And that is a very common scenario, right? For people have many dysfunctional joints, or not optimal for that matter, and they feel fine. And we never see those people, right? But when you accumulate injury over injury, you lose options for movement. And I think that's what happened to her. And so when I assessed her in terminal knee extension, when she went back all the way, the lateral translation of her, I'm on YouTube here, on her tibia was so apparent. I mean, she hyperextended her knee and that tibia went whoop to the right. And she went, oh my God, like even she noticed it. And so is that optimal for a healthy knee? No way. Is that optimal for a healthy knee? Right? She didn't get x-rays, but my guess is they probably wouldn't have shown anything. But that's not optimal movement. We need terminal knee extension to walk, right? And she didn't really have it in a very optimal manner. And so to make a long story short, that's a motion you need to assess, especially if someone's coming into you with issues with, I have hip pain when I walk, and it's when I place that foot in front. When you go into that heel strike, you're in dorsiflexion, knee extension, right? Hip flexion. So you want to assess both. Literally, you want to assess both components, but as I mentioned earlier, if you really want to hone in on one and be very efficient, hone in on the movement of the knee that has meaning for them. I mean, she didn't really connect with the squat. I just wanted to see what it looked like. It took less than 2 minutes, right? But the big thing is the terminal knee extension. And so shy of a structural issue, what do you think I won't go into the assessment because it's very clear that she has non-optimal muscle patterning around her knee. So when she goes into terminal knee extension, she gets that lateral translation. She said 2 hamstring strains. Do we think that's relevant? Oh yeah, big time. Big time. And she could adapt. We're talking 2015 was her first one, is 2024. I saw her this year. This is 9 years later. You don't think that knee hasn't adapted? That pelvis, that hip? Oh, heck yeah, it's adapted. And she made it so far, right? But when walking and things started to go wrong, and maybe she was walking more, she lost options. And so what you want to think about in that scenario is, okay, well, is there a weakness? Is there an overactivity? When I assessed her, it is very clear that she had an overactive hamstring. Ironically, because she didn't really rehab it that much after she tore it in 2015, right? And hamstring strains and tears tend to occur again, they reoccur. And so I think ultimately for her, she had a significant imbalance in her muscles. And if you think about what the medial hamstring does, right? And to think about the position of her femur, and when I watched her walk, you could see that significant internal rotation torque at the hip and the knee. It is consistent across all movement patterns. You know, in standing, she's got this. In terminal knee extension, she's got this. In walking, she's got this. Even in a squat, she was better. Not surprising since she had no problem squatting. So you want to think about the movement pattern that is very consistent across the activities that make her worse. Okay, and it was, Erica, I can't walk when I placed my right foot in front of me, and I basically said, "Show me." And it was when her knee was extended. And she also, had mentioned that standing doesn't really bother her much, but when she has to stand for a period of time, it did. Well, no wonder she's loading that right side and she's overactivating all of these muscles. Think about the hamstring. Where does it attach? It attaches to the pelvis and attaches to the knee. That muscle, that relevant medical history is pertinent to her situation. And so what you want to think about is, okay, how does that affect the non-optimal patterning I'm seeing at the knee? Joints don't like to be compressed. So if you have somebody, who says significant lateral translation in standing, and it gets worse when she goes into terminal knee extension, and that matches her story, you need to figure out why, right? And she's not even coming in with knee pain; it's hip pain. But those long muscles attached to both joints, okay, and that overactive hamstring, even I would say weak hamstring, right, was feeding into that torque or that twist in her hip and in her knee. Okay. So, but the hip is where she felt it, not so much the knee. And once again, it can be the opposite scenario. People tend to have a lot of knee pain and their knee isn't their driver. That is the more common scenario that I see. But she has had an extensive injury history. Okay. She's loading the side that hurts. You need to sort of think through that when you see your patients. At the very least, do their center of mass. Just put your hands on them, stand behind them, rest your hands on the top of their iliac crest, match your feet to theirs. Are they, to try to center them and see where they end up. Just try to, do this on everybody you see. You'll get really good at it. Put your hands on the pelvis, the thorax, the head. See where they're loading, right? See where they're standing. It'll be very easy. And you can even take a picture and then just mark it up and see if it matches what you're feeling with your hands, right? She was loading her symptomatic side, and you have to question, what does that do for, what implications does that have for loading? Significant. She's standing on her right leg. It'd be significant. No wonder her hip hurts, right? But her driver was not her hip. Okay, as a matter of fact, when I had asked her, I said, did you ever stretch the hip? She said, oh, that makes it worse. Figure 4, cross body. And like, okay, that clearly, makes sense to me because it wasn't her driver. So that actually made her worse. And so you really want to correlate her past medical movement history, injury history to what she's coming in for, and what, in her case, part of the gait cycle that made her worse. And it was knee extension. So everybody who's assessing knees and is not assessing terminal knee extension, you need to do that, okay? And if you see any kind of non-optimal patterning, you need to use your clinical reasoning skills to figure out, okay, well, what's the issue? So anyway, I treated her. I did a lot of soft tissue in the knee, and we did some terminal knee extension patterning. I had her do, her glutes also were quite inhibited because of this patterning. I ended up having her do, to start off with, just honestly basic bridging, but elevated bridging, mindful of her knee. Her feet were on like a stool or a weight bench, and just do elevated bridging. But I had her do a lot of self-release in and around her knee, medial hamstring, lateral joint line. Just take the thumb and go on the lateral joint line. I had her do a lot of that. I released her. So if I just had her lie on the table and her knee bent, for example, that would have done nothing. So I released her in full knee extension. And I assessed the ranges of dorsiflexion, plantar flexion, knee extension, knee flexion. And, the muscles that really were, turned on, we became hypertonic was when she was in that full dorsiflexion knee extension position. I had her off the table and sitting doing that. So you really want to assess, you really want to treat the muscles or release the muscles in the movement that sort of makes them feel worse, quote unquote, or in the movement where you're feeling some hypertonicity. And that's a whole other episode. But I did a lot of that, and I did a lot of patterning with some knee extension in the room. I'm actually in my room. You can see the buildings behind me. It's cloudy today. And I did a lot of that, and I have access to Pilates. So I had her on the reformer doing some full knee extension, but my hands on her training, really training because hamstrings tend to be very, very overactive. And at the expense of glutes and quads for that matter. So the key is that if you had treated her hip here, it wouldn't have gotten better, but really be specific and correlate the movements you're assessing with what she's telling you in her story. And I hope you enjoyed it. This is a shorty. I know whenever I say it's a shorty, it ends up being longer than I want, but as anybody has any questions, feel free to reach out to us at toughtotreatpt@gmail.com. We're looking to get listeners back on the podcast. We've gotten several emails from listeners regarding patients, long emails with patient scenarios, and it's really hard for Susan and I to go through that in an email. And so it would be best if you guys would love to jump on an episode with us. We could troubleshoot that on the fly with Susan and I, and it would make for a great episode. We did that a couple times already with a couple of the listeners. So if you want to jump on and have a patient scenario, please email us at toughtotreatpt@gmail.com. And thanks again for listening. And if you found value with our podcast, please share it with your friends. And podcasting world is enormous, and we're trying to reach as many people as we can. So thank you again, and Susan and I will be back with you next week.